Okay, thank you. Well, I'm delighted to be here today. I'm representing the, I guess, in the fields, trenches. I'm not affiliated with an academic training institution. I'm going to really talk about an organization that we really had to embrace training as a way of staffing ourselves, frankly. So I am with Cherokee Health Systems. Cherokee Health Systems is both a federally qualified health center and a community mental health center. So for those of you who are less aware, we really exist for the safety net to provide care. We see anyone regardless of ability to pay. We have been in existence since 1968, and as I've explained to several people today, Cherokee Health Systems really we're not part of a tribal organization. We're just named after a lake. The ladies who started Cherokee, there's a lot in eastern Tennessee and western North Carolina. There's Cherokee Lake, Cherokee River, all kinds of Cherokee shopping centers. So that's us. So we started as a very small community mental health center for children. It was called Cherokee Child Guidance Center, and it was started by Southern ladies who lunch. So I don't know if you know, but they just got together for lunch and said, well, we just think we need some mental health services for our children. So we were open on Tuesdays and Thursdays, and just slowly grew, and then really had an expansion starting in 1978 when our current CEO took over. And we have a saying, Cherokee goes where the grass is browner. And we have gone wherever there is need, and there is a lot of brown grass in Tennessee. So what we have done essentially since the early 1980s is we expanded into behavioral health, primarily because nobody wanted to see our patients for medical care. Then when we would go into medical care, we saw that we were seeing the same amount of pathology and the same patients as we were seeing in our mental health services. So we really brought the two together, and when people ask about how this developed, I say our patients showed us the way. I mean, it's really the families who showed up saying, we need this, we have this need, and we responded to them. So it wasn't any brilliant idea of ours, really, it was our community. So now we have expanded. Let's fast forward to now. We have, now we're going on 66,000 patients. We place a high value on access, so we have almost 16,000 new patients annually. And as you can see, we have a pretty broad range of clinical services, from family practice, pediatric medicine, oral health, developmental psychology, specialty medicine. We have a nephrologist and cardiologist. Joined our practice a few years ago. And we do quite a bit of telehealth, school-based telehealth. So we offer a continuum of services, and it's, again, because this is what our family needed. We offer cradle to grave. And one of the things I love about what I do is we get to see generations upon generations. So we work with families where we see the great-grandchild, grandchild, and so on up to the great-grandmother. And that's always really fun. We know the whole family. Okay. So these are the beautiful Smoky Mountains, and I have to tell you, my heart is really there right now. I'm just delighted to be here, but we have fires in Gatlinburg, and it's affecting several of our clinic areas, and in fact, one of the schools in which we do telehealth burned down. So all morning I've been texting, and we've got clinics in and around that area. So I've been texting, we're sending our response teams everywhere for both medical support and for mental health support. So here's some of our just basic strategic emphasis. Population-based care. We care about our population, and as I tell every person, we have to worry not just about people who are in our exam rooms, in our offices. We have to worry just as much about people who are not, because for every one person who's in there, there are 100 who aren't. So we have to be very population focused, and certainly our model of care integration is not a program for us, it's just the way we practice. Certainly outreach to the underserved, and telehealth has been an amazing way for us to expand access across the mountains of Tennessee. It's 7 hours from one end of our clinics to the other, so now about 40% of our psychiatric services are through telehealth. We offer telehealth primary care, telepsychology. We now have our community health coordinators going under bridges and into the projects and homeless shelters with iPads so we can provide care. So it's been a fantastic thing for us. Training, I'm going to talk about a little bit more later, but I will tell you it is the only way we have been able to staff ourselves, because it's one thing to have, kind of shortages in healthcare providers than shortages for healthcare providers for the safety net. Like, that pipeline is barely a pipe. It's got all kinds of holes and rusted areas. We have had to move into areas that have been kind of outside our comfort zone, and that includes value-based contracting. We have had to become incredibly savvy, and I'm looking at Marcy Nielsen because she knows for us to be able to provide the care that we want in a patient family-centered way, to be a real health home, we had to get good at getting things paid for, because fee-for-service widget pay per every little cough that you do, that's not going to fund finance. So we had to get good at it, and we've had to get very good at healthcare analytics. I have to tell you, now I am so grateful for my graduate statistics and methods classes, because now it's really about the data. Whoever has the best data is in a position of higher power and influence. And I'll be honest, our data is better than the payers. Their data can be a mess. So when they come and say, you did this, you didn't do this, and I will say, no, here is the data, and I can show you one by one. And it can also help us, most importantly, serve our population better so we can track what we're doing. So I'm just going to very briefly give you an overview of our model of care. We have an integrated healthcare home. We call it a behaviorally enhanced family health care. So our behaviorists are embedded in the primary care clinic. We also provide a continuum of specialty mental health services, and that allows us to provide access, same day, point of care access. Nobody should have to wait a day even to see a developmental psychologist or behaviorist. And so for us, that proximity is critical. We also started bringing developmental psychologists on board because we were having such a struggle to get our children who had scored positive on the MCHAT. Then it's like a 3 to 6 month waiting list to have the full evaluation. So we recruited and built our own postdoc for that, and now we have developmental psychologists embedded in primary pediatric settings. So I love that when we have any concern, we have them come in and they can do a full evaluation for autism within a week. And we had to set up an exam room, particularly for the serial trials behavioral intervention. In the pediatric home, that's the only place where our families would show up to bring their kiddos in for treatment. And then also, someone had mentioned siblings. We really worry about siblings with children with developmental disorders, right? So we automatically have our developmental psychologists meet with and work with every sibling just to provide that touch point. We provide school-based health to 20, now 3 clinics. And as I said, now we're worried very much about that one clinic in that community that burned down. We do telehealth. So we have pediatric nurse practitioners who beam into schools in more very rural areas. And that way, families can come when there's a child who is sick. They can go ahead and get care through e-prescribing. We can prescribe anything that parents need. And it is primarily because these parents live and work in Gatlinburg and they can't take time off work. Okay, so we also have Center for Excellence for Youth, which is care coordination for children in DCS custody. Okay, so I just want to highlight a few things for you. Number one, and we talked about this at our table, one focus that we have had has been to expand what we do into prevention, and wellness. So when we think about our resources, it's very easy for us as a safety net center. Honestly, we have people who are homeless, migrant, refugees, people who live in caves, families who have been truly disenfranchised and vulnerable. And it can be very easy for us to say, well, we're going to focus only on their illnesses. But we are really then not doing our job in terms of community health. We want these families to thrive. We want them to be well. We want them to live happy lives. And just because they're struggling with certain social determinants of health doesn't mean they can't do that. So one thing that I focus quite a bit on people is don't focus purely on Maslow's hierarchy, that if they don't have access to shelter or food, you cannot focus on wellness with them as well. You can. You can and you should. So when we think about resources, it's very easy to organize around just the sickness, but I show this slide to say it's about prevention and it's about wellness. This is our responsibility. We can do it. We can do it. We just have to be intentional about it. So here's my little pendulum. Please go to that. So let me tell you a little bit about some initiatives that can highlight what I've been talking about. Several people have mentioned the behaviorists and well child visits. Our behaviorists are embedded and they will see every single well child check. And the beauty about that is then if something comes up, the families already know this person. They do all the anticipatory guidance, they review all the screens, and it becomes a very efficient flow. One of the cutest things is we have a kindergarten roundup, so we do our kindergarten visits in a group, and it's just adorable. You know, we have different stations and we bring families in. We're able to knock out a lot of well child checks that way. The developmental and behavioral services in pediatrics has been something that, again, we've responded to the needs of our families. The other kind of component that has grown in the last 5 years has been our prenatal care or OB care. One of the major really tragedies that we have faced is the opiate epidemic in Tennessee, and I think it's happening everywhere. And I was invited to a Children's Hospital Leadership Council meeting, and they took us through the tour about 5 years ago to the NICU. And the worst experience of my life was to see these babies. There were like 3 or 4 babies there who had been born with neonatal abstinence syndrome. And I came back and I said, we have to do this. So we have to do something about this. Little did I know that fast forward to today, we had a visit from the Surgeon General just a few months ago as he was working on this new report. And in that same NICU, there were 70 babies with NAS. Crammed in. It was absolutely horrific, and they needed one-on-one nursing care, and it's just become a very tragic situation. So we have built in an entire integrated care team. We have 3 OBGYNs, we have a addictionologist, we have social work, psychiatry, psychology. We bring them together, and these women, we bring them through the entire process during their pregnancy, delivery, and then also we bring in our pediatricians so we can track these kids. Some of the lessons in cultural humility, people had said they wanted me to share in some of our work. Just so you know, fresh water, agua fresca, is not the same thing as fresh water. So in our pediatric obesity initiative, I mean, we were all saying, this is great, you're drinking fresh water, but no, it's a very delicious high sugar drink. We had the other thing we learned about in our interventions was what is a healthy body? What if you're Hispanic, African American, Appalachian, in the inner city, that is different. A little bit about training. The health education is critical to us. We are an area health education health center. I don't know if you're familiar with that, but we are a hub. We train multiple professionals, family medicine, pediatric medicine, psychology, social work. One thing I always push is a team of experts is not an expert team. So we want you all to learn together. It's not just about being really good at your one area. It's how do you be part of a team. This is just a little bit about our outcomes. We've continually track outcomes, frankly, because it helps us gain more resources to do better work for our patients. I will just leave you with this in terms of what's worked for us. As I mentioned, we went into training because we couldn't hire providers. Nobody wanted to come and work in Tennessee with an underserved population, so we decided to grow our own. So as you see, we have grown like gangbusters, and what I tell folks is, if you're not gonna work for us, please go out and work in a safety net population. Go where you are needed. Go where there is need, and always, always work as part of a team. And I'm happy to say now, 12 years later, over 100% of our former graduates work in interdisciplinary teams and for the underserved. One other piece I would leave you with is there is nothing like clinical immersion. We have everyone shadow everyone on the team, seeing what it's like. Our behaviorists shadow our primary care providers, our medical providers shadow our behavioral providers. That's been a very common theme, and combining that with mentorship is critical. The culture of the training that we provide, the culture of any system is important, and I hope what we can share with you today is a real respect and value and participation within the community in which we are a part of. So, thank you.